pleasure and honor, and thanks to AIOS for the award and the keynote lecture. Can we have the presentation displayed there? I can see the presentation. Thank you. And as you heard, it is about acute fluid misdirection and iridozonular vitrectomy in that acute setting. So we did a retrospective study to assess the outcomes of IZHV as the treatment for acute intraoperative acute fluid misdirection. And this was over a period of 5 years that we were able to find seven cases. The acute fluid misdirection was defined, please pay attention to that, acute shallowing of the anterior chamber with iris prolapse, inability to inject viscoelastic, forward movement of the capsular bag, intraocular lens or the phakic lens with a normal fundus glow and external factors being ruled out. And the confirmatory finding that these findings are resolved when IZHV is performed. Sorry, I went in the wrong direction. So there are a few external causes which need to be ruled out first. So this is just a protocol or table which one can actually follow to reach a diagnosis whenever you start seeing a very shallow, tense globe with shallow anterior chamber. If you obviously see a brown mound or the loss of fundal glow, you can be quite sure of a suprachoroidal hemorrhage or a large choroidal effusion happening. And in that case, you have to just close everything, go back to your prayer room and hope everything is fine next day. And based on the clinical and ultrasound findings, manage it thereafter. However, if you don't see a loss of glow, you have to rule out an external factor like the patient straining because of holding breath, wanting to urinate, coughing, or the speculum being tight. And they have to be managed, of course, accordingly. Once that is ruled out, we have to ask the patient if the patient is feeling any pain. Any suprachoroidal hemorrhage or an effusion is likely to be associated with severe pain, and hence, once all of these are ruled out, we reach the diagnosis of intraoperative fluid misdirection as a diagnosis of exclusion for which an IZHV can be performed. Now we noted everything, the anterior and posterior chamber findings, the visual field biometry, reviewed the surgical video and kept a special eye on further shallowing of the anterior chamber in the post-operative period. Now this is a rare condition. Very few occasions in your life you will find this, and only because we deal with these large number of cases, we have been able to collect these 7 cases. 4 of them were undergoing a combined cataract and glaucoma surgery, and 3 of them were phacoemulsifications. 4 again were angle closures, and 1 of them was a pseudoexfoliation glaucoma. 1 of them was a normal non-glaucomatous eye with high myopia, and 1 of them was a open angle glaucoma. I'll just use this video to demonstrate what I'm talking about. So it all started very easily, calmly, as a patient who was undergoing a cataract surgery, open angle glaucoma, high myop, and you see, I'll just pay attention to this floater here in the center on how it has moved from periphery to the center and seems to be coming up near. And after the IA, when the AC was left shallow for a while, it became very difficult. The globe became tensed. The posterior capsule was getting stuck to the anterior capsule, and iris kept on prolapsing. Any attempts to dilate or form the anterior chamber by injecting viscoelastic was failing. The viscoelastic would be vomited out. And then I had a dilemma. I had the option of either stopping here and abandoning the surgery, proceeding the next day. Even attempts to inject the intraocular lens failed. Call a colleague from the vitreoretinal surgery department, or do something that we regularly do for a chronic aqueous misdirection. So I decided to do an IZHV, and you see the vitrector going into the peripheral iris at a site which is not hidden by an incision, And if you watch carefully, you'll find a point of time where you see the pupillary snap sign, not a sign that the anterior segment surgeon welcomes, but here it was the landmark of things going right. So as the anterior hyaloid face is broken, there is a sudden change in the dynamics of the eye, and after this pupillary snap sign, everything went on well, and the eye started behaving completely normally, and I was able to complete the surgery uneventfully. Now, these are the settings that were used for that particular machine, or most of these patients. We were using the Alcon Infinity at that point of time. Very importantly, during the iridectomy, the cut rate has to be low with a high vacuum, and the direction always has to be away from the ciliary processes and the iris root. And while going through the capsules, make sure that you don't damage the capsule too much, because then you don't want your intraocular lens hanging up and down. So all of these patients resolved. It means that the anterior chamber was no longer shallow after the procedure in the immediate operative or the post-operative period. None of them had a recurrence, and the intraocular pressure was controlled, though quite a few of them required anti-glaucoma medications. There was one patient who needed a ND-YAG hyaloidotomy for a fibrin membrane that had formed at the site of the IZHV. Apart from routine steroids and antibiotics, we did use atropine and a combination of tropicamide and phenylephrine, which were very carefully tapered over 2 to 4 week blocks. Now
it's 8 minutes. If you have to, it's 8 minutes.
8 minutes.
Yeah.
Just give me 1 minute.
Okay.
The confusion in the terminology is also matched by the confusion in management. While the acute condition has never been reported to be managed by IZHV, IZHV is considered the gold standard for a chronic aqueous misdirection. Same pathology, but this treatment has not been used. So we happen to be the first series to actually publish this as a modality of management, and the outcomes have been good. And with this intraoperative technique and postoperative careful medical management, the anterior segment surgeon, I believe, can carefully, successfully manage this dangerous condition.
I think this is a
Thank you.
Thank you very much, Siddharth. At some point, we need more time for you to tell us more about it. Thank you so much, and congratulations.